This is Dr. Ben Pearl. On the next episode of Fitfoot U, we're going to be talking about podiatric research. We'll be talking with Dr. David Jenkins, who will be talking about, amongst other things, dogs that can sense a diabetic ulcer by smell, or when a diabetic is having a hypoglycemic or hyperglycemic event. We'll be talking about this, the Special Olympics, and much more coming up next on Fitfoot U.
For anybody to be hurt. You've got to get my dad.
Hey everybody, this is Dr. Ben Pearl with Fitfoot U, and today I am honored to have a fellow of the American Academy of Podiatric Sports Medicine and also faculty at the Arizona College of Podiatric Medicine, Dr. David Jenkins, who's been practicing since 1978. And I wanted to take a departure from the 70s running boom with podiatry, which I'm sure is part of your interest, and you'll tell us a little bit about that. But the focus today was going to be a little bit on research and how research has evolved and how that has blended into the curriculum with what you're doing now. So welcome, David.
Sure. Thank you so much, Ben, for asking me to join you, and love to share the message of what we're doing here at the Arizona College. And as you mentioned already, I was in practice in California for about 10 years, and it was a very much running related sports medicine practice. And because I was a very competitive runner and still am throughout my life. And then I got, to be totally honest, I was not thrilled with the business side of things. And I took a position at the Des Moines College for about 12 years. It was very clinically based as far as my position, and did very little research while there. But then, long story short, ended up coming to the Arizona school when it started in 2005 before, and immediately kind of weaned out of the clinical side and got very, very much interested in research. And what I was going to share, especially with you today, was student research, because every project I've been involved in here has had students involved. And I would say most of the projects were student generated. You know, just for an example, a student would walk in my door and say, I want to do a project on skateboard shoes. And we're still she's now a second year resident, and we're still trying to get that project, finished.
And it's an Olympic sport.
Yeah.
I saw that young Brazilian, I think that I don't know if she medaled, but it was quite a trick what she did,
It's so ironic you'd say that, because the last Olympics, she was watching on TV at her house and I was at my house. And we saw these skateboarders, and we were looking at the shoes they were wearing and texting back and forth, look, get some pictures, for the study. But that's kind of how it works. Another student walked in and said, I was a ballerina in one time, and I wanted to trying to see when is the best time that someone can go on point. And as you can imagine, it's super controversial. And so that's a project we're involved in right now, trying to get a good feel for, when is the best time to go on point. But I'd say the majority of my projects have been related to Special Olympics, which I got super involved in 2006. I'm a clinical director here in Arizona, and I've had students involved in all the events since then. I've been to every World Game since 2007. And it's just been a passion, and it's been something that's also created a lot of opportunities for research. Again, students help with these projects where we look at basically prevalence data of how many athletes have flat feet, how many athletes have shoes that don't fit, stuff like that. So,
yeah. And you also told me you developed or helped develop a fit screening type protocol evaluating the feet for the Special Olympic athletes.
Right. And if you've done fit feet before, it's just a basic screening of the athletes. It kind of emphasizes biomechanics and structural problems and a lot of dermatology. But in the past, we've never done anything with regards to diabetes screening or risk for diabetic foot ulcers, which is obviously a huge thing right now. And so I suggested that we maybe include that in fit feet. And so in the process, a couple of my students, and affectionately known as the Hannah Montana Project, they're both residents now, but they went and we had a study with athletes at Special Olympics Arizona, where we didn't assess protective sensation. We assessed whether we believe the athletes could actually understand the Sims-Weinstein test. because the dogma was, well, the athletes won't know how to do that. And I didn't think that was true. So indeed, we found about 70% of the athletes could understand how to do Sims-Weinstein. So we're going to include lack of protective sensation, pulses, and other factors that you might include in a diabetes screening. So that was a really wonderful spinoff from that pretty simple pilot study that we did.
As a moving forward, would that be something that you might give to athletes in a kit so that they could have that and stimulate interest in, just being in touch with their body a little bit more, that type of thing as well? Okay. Can you take me back to what research looked like in the running boom? Because I myself, I was part of that running boom, but I was in high school. You were already kind of like getting towards, that seminal part of your what could have been your seminal part of research. I don't know how much you were doing back then, but it seems to me at that point that there was a lot of like old saws that were, okay, we're going to post this in valgus. There was even debate, orthopedics, it turned out, was correct about taking off the medial compartment by putting you not into verum, but into valgum. So they, with the osteotomies. But maybe talk to me about, I know it wasn't shooting at a dartboard, but at the same time, maybe not as robust. So what is your recollection of the experiences of how data was being disseminated back then?
Sure. As we just mentioned a minute ago, before we started the show, the only research I was involved in when I was in practice, and practice went from 1980 through 92, and was a project I worked with Kevin Kirby on with a grad student at UC Davis. She was studying the forces through knees as per certain different foot positions on the pedals. And that was the only actual real research I did at that time. But I got involved in podiatry because of running. I was a competitive runner.
Where did you run?
I was a 400-meter runner ultimately, but 200, 400, 100 relays was my specialty. We actually won California State in the relay. So it's just been in my blood. And so in the mid-70s.
Did you do any like club teams after, like here they have the Georgetown Enclave, or formerly, I think that was in the 80s, very popular. The Centrowitz's, I think Centrowitz Senior was through that as well. Was that, did you reach that level as well, where you were doing like club teams?
No, not quite that level. Once I got to Davis and was in this case, pre-med, it just wasn't, I wasn't one of those that could study at that level and also do sports. So, but it was always in my blood. And of course I did, unofficial competitions since then, a lot of triathlons and just fun runs and stuff like that. But what I was going to say is I got interested in podiatry because of the running craze. And there was a big conference in the 70s with Steven Subotnick and Harry Levac and a bunch of orthopods, and just talking about that runners were so perfect patients for our profession. And you probably remember George Sheehan, and he had mentioned that the podiatrists were the runners' doctors, and that set the stage for our profession. Just go crazy with runners and become so heavily involved. So, but to answer your original question, no real research. The only thing I remember was one of my professors, Dr. Bogdan. He talked about a varus wedge for everybody. It was like that was, everybody's overpronating, and just that was the very beginnings of biomechanics with runners. And so
what was interesting, and to your point though, is there was a lot of interest in cycling research too at that time. I think in the 80s, you had Nelson Vales win an Olympic medal, and there were U.S. cyclists coming up through the ranks, and I think that also stimulated, and obviously a lot of research coming from Colorado Springs. So I think that also trickled down somehow into our world as well.
Yeah, and one thing I do remember, Dr. Levac, Harry Levac, he developed the biopedal and for cycling, and what it allowed you to do is change the position, the frontal plane positions of the pedals, and obviously, the transverse as well, which was eventually, that was not a problem. We went to floating
and then
pedals,
having some float also.
It was something that he was pioneering at that time to try and address the fact that, and again, this goes back to the project with Dr. Kirby, was that there were issues with people's feet in the frontal plane that were not being addressed by just standing on the traditional pedals. So it's that was, I remember that was quite a big deal back in the, I'm going to say mid 80s or so.
What are some of the projects that specifically that some of your students through the time you've been doing this have been able to elucidate that, okay, now we know this because of this study? What are some of the maybe the highlights that you can think of that have been interesting to you?
One of the big ones was barefoot running. At one time, one of my students who was a barefoot runner, he came in and said, I want to do a project on barefoot running. And this was when it was very quite new. I'm going to say 2010-ish or so. And pretty much all you saw was just stuff on the internet and, studies that were not really studies, but people would see that, people had better balance if they were barefoot. So that must mean the barefoot running is fantastic. And so we just took a really hard look at the literature and essentially came up with the final conclusion was there's no literature out there that says that it does all these things, but there's no literature that says that it doesn't. So that's been an evolving issue as barefoot running since then. And so we've updated it. And
well, yeah, I mean, I was asked to do a piece with MSNBC once with Dr. Nancy, and you had your zealots, and there was a certain mystique after the book Born to Run. And obviously, we know now that a lot of this so-called anthropologic data wasn't really, it was just sort of speculative. It wasn't really based on any notion of what's actually happening with the kinematics or kinetics of the foot.
What I share with the students now is it's what we call the barefoot condition, running as if barefoot, with all the aspects of that. A lot of people are doing minimalists now. They're kind of doing the barefoot method with shoes on and good form running, things like that. But there are some good research topics coming out, putting patients with, say, medial compartment knee pain, osteoarthritis and iliotibial band syndrome and some other of the sports medicine conditions that if patients utilize the barefoot techniques, in many cases, it does help them. So that's about where it's at right now. It's constantly evolving. But that was one of the very first projects that we did. And then we've had 4 Special Olympics projects that are, again, just mainly prevalence things, how many athletes have shoes that don't fit and such. Rock climbing shoes, we did that with Dr. Page, who was the dean at that time here. That was kind of fun too.
What did that conclude? The rock climbing?
That was also around 2010. And that was a student who her sister was a professional rock climber. So the student and her sister and Dr. Page and I and Dr. Wisman, who's here as well, did this study on rock climbing shoes. And so that was another, again, publication generated by a student, which is.
Did it have any strong conclusion one way or the other about what helped?
We found that the rock climbing individuals that we surveyed were not necessarily sizing their shoes like up to 2 sizes too small, which was kind of the dogma at that time, that all rock climbers wear shoes way too small. It wasn't quite that extreme that we saw. Most of the rock climbers were willing to put up with all the issues at their feet if they felt the shoes were giving them, better feel, better fulcrum of strength, etc. So, but it was just kind of a fun thing to put together. And the skateboard shoe has kind of been going in the same template, if you will. We're still waiting for that one to, I guess.
You had mentioned an interesting one that a student is doing with some anesthetics and bicarbonate or anesthetics, buffering the anesthetic.
Oh, yes, that was one we talked about a while back. That's brand new. We're right in the IRB process, and the thought is that if you neutralize the lidocaine with a little bit of bicarb, it doesn't sting as much. And so we're going to do that right next door in our lab and with just students here, so keep it kind of simple and just the design that the students are doing is exceptionally good. We're meeting with the biostatistician next week to get their side of things and find out how we can make the study better or that kind of thing. So
for those that are, David, for those that are interested in the IRB process, do you do yours internally through the college, or do you have an external?
Well, through Midwestern University. The university oversees all the colleges here.
That's a big one, as far as I understand. I think a lot of studies with podiatry anyway go through Midwestern.
Yeah, it's a major, I guess, organization here. The IRB, it's very challenging to deal with. Anybody that's dealt with IRBs know it's not often easy.
Can you, I
Yeah,
know
got all
it's getting into the weeds a little bit, but for those that really are truly interested in research, kind of give them a little bit of a lay of the land of what they're going to be encountering with the challenges, because I know it can be a pain.
Sure.
I've been through that process,
Yeah.
conflicts of interest. You can't get money, but then how are you going to generate the funds to pay potential volunteers if you can't get a sponsorship? So maybe give us some of the
Well,
things that you have.
all my projects, I mean, I would say just a couple of them didn't require IRB, but most of them do. And we've gone from paper submission to it's totally online. They have a very, very, I don't want to say easy to use, but it's usable, I guess, system of doing the IRB. And we have a committee. It's made up of faculty members, and the students, I try and get them as involved as I can to give them access to the IRB document online and let them do the best they can with it. And then we go back and go over it and see what we could do differently. As you know, it doesn't matter how perfectly you do it, you're always going to get feedback, fix this or change that. And so that's a little difficult sometimes, but we get through it. And we also have something called RedCap here. RedCap is again an online tool for doing surveys, and it links to the biostatistician. So all the data that comes in goes right to them so they can see it. We meet with them. I'm not a biostatistician. I can barely figure out what a p-value is, but we have, and the students, as you can imagine, are very well versed on stats, way better than I am right now. And then again, the biostatistician is the one that really does the heavy lifting with our projects when the data comes in. Like the ballerina study survey data just came in. And so now we're going to meet with them, the biostatistician. And so what do we do with this? How do we write this paper? Because as you probably know also, surveys don't retrieve as many responses as you would like in many cases. And that's been true for a couple of my projects. So you just do the best you can with that situation. One other project that was also a student that came in was diabetes and exercise. And as you know, exercise is fantastic for diabetes, and we have a whole lecture on that in sports medicine. But our paper was about, well, how do we get our patients to exercise when they don't want to exercise, and what can we come up with? So we came up with a solution of hiking here in Arizona. It's hiking, you're out in nature, it's nice scenery, the terrain is undulating, so you're constantly changing the pressure points on your feet, which is good. You can use poles, which help get the arms involved, help with balance for some persons with diabetes have neuropathy and some balance issues. So anyway, it was kind of a really cool project. My dog's pictures in the publication, which is really fun. But we did two of those papers, one for Journal Foot and Ankle Surgery with them all. Saxena, he had a project where we got a bunch of us together and we talked about that in there.
I know Bijan Najafi, to that point about exercise, also talked about, in a different way, gamification, he calls it. So let's say you're on your online apps and you're doing things that might involve movement, and you get a score, so you make a game. So somehow you tie the leg movement into something that is hooked up to some kind of video game or something, but that is encouraging movement. So yeah, no, all different ways to make it more interesting and more varied.
Another fun one that just popped out of nowhere was I actually have been teaching at the vet school here. And I don't even know if we discussed this, but for 10 years, I was with the sheriff's office here as a canine search and rescue dog handler. And so I taught search and rescue techniques and also military explosive detection with dogs to the vet students. And one of the vet students I was assigned to do her, project, I guess, her research project, she decided to do hyperthermia in canines. And so that was kind of cool, went through that. And then the next student I had, she said, well, let's do diabetes detection dogs that can actually sense an oncoming hypoglycemic crisis, for example. So she did a really nice presentation and a poster and all that. And so a couple of years later, one of my podiatry students came by and said, I need a project to do. So that, why don't you do this project in diabetes detection dogs. So indeed she did. And long story short, we finally got it approved. It should be coming out in JAPMA in the next month or two, but it was just an amazing experience of finding out how little people know about what diabetes detection dogs can do, how they're a nice tool, especially for some patients that can't use the glucometers properly. And so we just had a really great experience with that. And then as a follow-up to that, and this is another, I guess it's a pub that we're hoping will get published soon, is what about dogs that are with a person with diabetes that is asleep, that's neuropathic, and they're getting a developing ulcer. The dog goes over and decides to consume their foot. And so at first you're thinking, well, that's pretty weird and pretty rare. It's not rare at all. I've had students email me, text me from all over the country. Oh my God, we had a case of this at the hospital. And so we got 3 really excellent cases, actually from Central Michigan University residency, with beautiful pictures. And just, it's going to be a case study publication, but it's just an amazing thing that people don't really realize is actually occurring out there.
So the dogs were able to track and smell the Pseudomonas. Is that where we're going with
Whatever
this?
the bug was, it was necrotic tissue, and they're attracted to it. And so the take home is, if you have diabetes and you got a dog, you better cover your feet while you're sleeping, because they may do that. And being completely neuropathic, they don't even wake up while it's happening.
Yeah, and is it that sophisticated? Because I know nothing of this area, David, and I don't know if it's discerned, because hypo or hyperglycemia could both be problematic, right? But are the dogs able to distinguish the two? Can they be trained to actually pick out which situation?
Right. Now, going back to the diabetes detection dogs, they are trained to do hyper and hypo. And what we found, because a lot of this was new to me too, I wasn't really an expert in this area till we really started doing all the research. And we found that they're trained to do both, but what they're trained to do more than just smell is behavioral changes. So your dog, if you have a dog, you know how much they know you. You just you just change your voice a little bit and they'll go, what's going on there? They're that
ears perk up, right?
To their owner, right? And so if you start having a hypoglycemic crisis, you might start talking differently or moving differently, or it's not just the smell, it's the behavioral changes that they cue in on. And they might start barking, they might sit, they might lay down, they might, they have a behavior, what we call an alert, that's done, that marks that behavior change that you have, or that odor that you're developing. Because again, the acetone odor that they might
or ketone
produce if you're hyperglycemic. So they're trained to do all of that. The other thing we found is that the training is very, very inconsistent across the board. So a dog that might get certified in a super fantastic program is going to be very different than one that the patient just trains in themselves. So the studies that actually looked at how good the dogs were all over the place. And so that was our final, I guess, conclusion, was the dog has to have really good training to be consistent.
That's really fascinating. And I think a lot of people, I think this podcast is going to generate a lot of interest in this. I can just hear the dog hotlines ringing. So hopefully they're ready.
We'd love to be able to get to the point, and this is actually something that we've talked about, where you have a dog that's trained to alert to you if you have an impending ulcer that maybe you're not aware of. Maybe you can't see, maybe you can't reach it, but rather than eat your foot, the dog just does an alert, like if you were in a hypoglycemic crisis, and say, oh my gosh, I need to have this checked out. That's something that we've thought about and talked about. It would be a pretty big study to try and develop that, but we thought
now,
about it.
Does it go in so far as, like, they're not only barking, but the dogs can be trained to, like, Lassie, like, Johnny's, knee deep in the river. What is it, Lassie? And then they go and get to somebody. I mean, can they do those kind of behavioral training things as well?
Sure.
Yeah.
It's amazing. You can train the dogs to alert probably any way that you want them to alert. Like in most of the search and rescue, my dog was a cadaver dog, so he was looking for human remains. And the scent of human remains is the same for everybody. There's not a distinct one for you or
Yeah.
me, or it's consistent. And so the alert that most of us did was a sit. So the dog would sniff in this case, the human remains little can that has it in there, and sniff it and sit. And that was what we call the alert. For the other dogs might bark, other dogs might lay down. It just seemed to be easier to have them sit. And that could be something done with the hypoglycemic crisis as well.
That is really cool.
Yeah.
So, yeah, I love that. So let's get in the home stretch here, because you were mentioning about the curriculum you have, and I just learned, after I spoke with you, that, or maybe through you, that Dr. Joseph is teaching an evidence-based medicine course to teach people how to find the up-to-date research and to emphasize that, hey, if you're looking at data saying that osteomyelitis six weeks of antibiotics, that may be antiquated. That may be 80s research, but not what's happening in 2024. Tell us a little bit about some of, because I know you moderate a little bit with that, about some of the misconceptions that people might have about evidence-based research, other than the obvious that, information continues to evolve. We know this, but what are some of the things that maybe you've gotten out of it or students have gotten out of it that you could share?
Yeah, well, Dr. Joseph joined us a few years ago. He's one of our faculty now. He lives up in beautiful Sedona, which is about an hour and a half north of Phoenix, but he comes down and runs that course, and it's got librarians involved, and they teach basic search principles. And then, of course, the big thing he, I guess, oversees, and I'm one of the moderators, Dr. Violins, one of the moderators, is it's kind of like a journal club, but he gives them specific assignments of what kind of articles that they're supposed to give. He wants them to get for example, a meta-analysis article. And so they get this article and they all participate in presenting the article to the group. And then another article talks about treatment. Another article talks about basically the condition or whatnot. And so, but he does really train them how to review an article in detail, the levels of evidence, things that I think most of our colleagues are aware of, but it's so important nowadays. And when we were in school, the main evidence was what our professor told us, which is now considered the lowest level of evidence there is.
Yeah.
But they random controlled trials or things that they want to look for, and obviously a good meta-analysis is the ideal. So it's just a good solid course that they're second years, late second years. They're just finishing their second year when they take that course. And
I have to tell you, though, from me talking to colleagues, I think that this would be something that would be good to have in a more Reader's Digest way, with slightly different material for seasoned clinicians, because I think a lot of people, we'll get a pharma rep, and I literally remember, this is funny, I remember a pharma rep bringing me a graph with their no numerical data. It was just this line, and I'm like, what is this? So I mean, if you don't even have that much level of I don't know, I shouldn't say skepticism, but just sort of discerning what you're looking at, you're not doing yourself or our patients any favors.
Well, I'm an example of what you just said. When I was in private practice in California, and when I went to the Des Moines school, everything changed, and I realized how much, as just a clinician out in the general practitioner out there in the world, doesn't keep up as much as they should. I was guilty of that too, and I felt I was pretty up to date on things. But when you get to a teaching institution, you start seeing things like you're talking about, evidence-based medicine. Oh, what's that? I better learn about that one. And then, of course, we had some really good, obviously available resources for that once I got into the academic world. And we had a course for it at Des Moines as well. And so, of course, we have the one here too. And problem-based learning was another thing I was introduced to at the Des Moines school. It's very time-intensive, work-intensive. It was very effective, but it's just hard to put that together with a large number of students. But it's a great way to teach.
For those that are interested in the type of research that is ongoing, is that public domain? Could interested clinicians look up what's happening at Arizona on even like the student studies? Is that accessible to the public, or is that its own internal portal that only the
No, I
faculty
think it would be
have
something.
access to? Mm-hmm.
It would be accessible probably on a one-for-one basis, like access mine, access Dr. Violins, access Dr. So-and-so's. I don't think there's one big place. I could check, with Dr. Jensen for you and find out, but and I'm happy to share any of the things that we've been doing. I think we covered pretty much all the projects I've been involved in. The biggest one that we haven't mentioned, I just don't want to leave without saying, it's kind of been my passion is developing a curriculum for intellectual disability in all healthcare provider institutions, not just podiatry. We're going to share this with all of our programs and colleges here once we get it done, but it's been a massive project. We've met with every dean and program director at Midwestern's 20 different programs here. So said, what do you do for training your students for taking care of persons with intellectual disability? Got all this stuff compiled. Now it's just a matter of putting it all together. And I've lectured on this in several venues, including AADMD, which is an organization that's specifically for not just ID, but developmental disabilities as well. And
does that go as far as to track things like attention deficit disorder, or is it more
not
IQ?
What I'm doing? No. When you start looking at AADMD, the organization that covers developmental disabilities, that would be in that umbrella. But our project is simply for intellectual disabilities.
Mm-hmm. Great. This is all good stuff. So if people would like to find out more about what you're doing, and you already mentioned to me, but let people know if they want to volunteer with the Special Olympics, which I know it's your passion, and you're getting to go to Italy for the World Games. That's cool. Turin, I guess.
Yeah.
Is that where Tomba lives? Is that where
the academy
Tomba
meeting?
Here?
The academy meeting, which is later this fall. The young lady who oversees healthy athletes and fit feet and fun fitness and I are doing a co-presentation on Special Olympics and Special Olympics research. So some of the things we just talked about will be in our presentation. So that'll be there if you're going to make it to the Academy's meeting. And
yes, I will. So I look forward to that. So how would people, if they're interested in finding out more about the kind of research you're doing at the college, where should they look, David?
Well, my email, which I don't know if that's something you can post or if I just need to share it right now.
Yeah, please share it, and then if I can, I'll figure out a way to link this when we do the blurb at least for DPM News.
D as in David, JENKI at midwestern.edu.
Okay. Final thought, and I just want to get your take on this. You started when podiatry was sort of owning the run space. So maybe just a couple thoughts on what we need to do now that it's been more diluted. We have a lot of retail options. We have physical therapy running clinics. I just turned on a podcast where a chiropractor was the featured one, not a podiatrist, about the best way to develop minimal running. And David, I have to say, it's not like I never hear a podiatrist on the Today Show, but more often than not, I'm finding it's some celebrity type doc, or maybe another specialty, or an athletic trainer, or somebody that's just doing retail running. And a lot of that is, of course, directed at sales. But what do you think is some of the things that podiatry should be doing at this point, with this juncture and where we are with kind of taking more of the forefront of the gate space? And
well, I think it starts at the schools. I went to the California school, and Dr. Root and Weed were professors there, and so I got a tremendous biomechanical background there. Of course, some of the students that were near my time there, Kevin Kirby, Rich Blake, Richie, some of the really incredible biomechanists in our profession, and they're out there. I was honored to lecture at the Western with a few of them, and so they're there and they're doing phenomenal work. We can't control the media, but we can just try and get out there and do a better job of making ourselves available. But again, getting back, it starts at the schools. And I can tell you here at this school, I don't know about the other schools. Biomechanics is a really big deal. Dr. Toms is one of my colleagues, and she oversees the biomechanics here. I'm pretty much helping all of her labs. I do a few of the lectures, but mostly I just help in the labs. And our students, whether they carry it with them the rest of their careers, I can't say, but they're getting exposed to it. And in Special Olympics, when we have fit feet, as I mentioned, a big part of fit feet is biomechanical evaluations. Very simple. I mean, things that are not high-powered Kevin Kirby things, but they're still showing them the importance of gait analysis, the importance of doing a good biomechanical evaluation. So that's what we're doing, and that's what I think all the schools need to be really taking the emphasis a little bit away from surgery, because as you know, that's been the evolution is away from biomechanics and more to surgery. And I think we need to have both of them emphasized strongly.
Yeah, yeah. And there are some lectures. I did one recently with Dr. Patrick Tahir out of Indiana, and he's one of those practitioners that really can blend both, and not only the gait part, but the sequencing of what happens, if you stage a surgery, et cetera. So there's obviously a lot of nuance in the particulars. Devil's always in the details, right? Well, listen, thanks for doing this. It's even more entertaining. It took a dog leg left with the canine stuff, but I'm glad it did, because that's you educated me on that, so I appreciate it.
I think it's fascinating, all that stuff. One last little thing I'll tell you, since you're kind of jazzed by the dog thing, and this is going back to when it was going through review for the journal, and the reviewer was apparently a veterinarian, and they said, well, this is something everybody knows about, nobody's interested in. And so, well, we had quite a resistance to that. And because the day before that reviewer came back, we have our big poster contest here, the Kenneth Schwartz poster day. And out of 200 and some posters, that poster for the dog, the diabetes detection dog, was picked the #1 poster to be presented orally out of maybe for 8 or 10 things, because of its interest. Everybody was so interested in it. So it's like, of course it's interesting.
Yeah, we just took a rescue dog in. We named her Maybelline, and you really truly find that dogs are the universal. They are the common denominator. Yeah. Especially we're at a very, we got the election coming up. It's very politically charged and such, but when you have a dog, you're all the same. So
Gotta have a dog.
Yeah. Thank you again, and looking for you at Columbus, and those that want to hear, colleagues out there that want to hear your talk, please come out to Columbus and go to the standalone meeting.
I'll be there. I already got my flights. They're kind of crazy with the airlines and stuff right now, but yeah,
I need to get mine. You're reminding me. So,
and I'm hoping a few of my students will be able to make it out there as well. Some of them that have been involved in these research studies. Would be wonderful for them to go to the Academy meeting. It's a great experience. Best meeting in the world, I think, for sports medicine from the lower extremities. So looking forward.
I agree. That would be awesome.
All
Thank
right.
you, David.
Thank you so much, Ben. Appreciate it.